Good morning, everyone. Crowded room. We are going to talk about composite endpoints in clinical trials. This is something that you will see very frequently in clinical trials, in published trials, even in the high impact journals. Researchers frequently use composite outcome, and we want to know the advantages and disadvantages of composite outcomes in clinical trials. So, as you know, there, just briefly, let's talk about different types of outcomes. You have primary outcome. This is the main outcome, whether it's efficacy or safety. This is the main objective of your trial. This is the most important outcome for you that you're measuring. And this is the outcome that you base your sample size analysis on, right? No question about primary outcome. If primary outcome is positive, if you find the significant difference between primary outcome, you can look into certain secondary outcomes to see if the benefit extends beyond the primary outcome. For example, if your primary outcome is mortality and you show that your treatment reduces mortality, then you can look at some secondary outcome to see if the outcome reduces ICU requirement, it decreases the length of hospital stay, and some other outcomes. And I repeat, only if your primary outcome reaches a significance level, then you look at secondary outcomes. Secondary outcomes on their own are not built to change clinical practice. They are not built for drawing conclusions, right? And then you have exploratory outcomes. And these are outcomes that you know are very infrequent. You're not going to have enough number of outcomes, but you just want to get a sense of their frequency so you can build your future studies. These are hypothesis generating outcomes. Surrogate outcomes are, a surrogate means substitute, right? So you substitute an outcome that is important to you with something that is less important, but you want to extrapolate from that substitute what is going to happen to the outcome that matters. For example, in trauma research, when you're looking at efficacy of a study, it's the main thing that matters to you is mortality, right? But the mortality from trauma is low, right? 1% or 2%. If you want to show that the treatment affects mortality, you need thousands of patients, and that might not be feasible. So instead, people use, let's say, blood transfusion requirement or massive blood transfusion requirement, because most people who require massive blood transfusion die. They extrapolate that if you have a significant difference between people who require massive blood transfusion, we extrapolate that probably more of them are going to die, something like that. Or another good example is that antibody cocktail, right? The antibody cocktail that is being forced down our throat to give to the patients with COVID. The study, the primary outcome was viral load, right? So does it mean that if you have higher viral load, you're going to get sicker, you're going to need intubation, you're going to die more? I don't think so. I don't know. But they're using that as a substitute for the outcome, which was illness, severity, or death. So that was a substitute or surrogate outcome. By the way, that study that FDA made FDA approve it, didn't reach, even for the viral load, didn't reach significant and the primary outcome, and they did some post hoc secondary analysis, which we have talked about here many times, that you're not supposed to use post hoc. And even if it was pre-planned, it still is a secondary outcome. They looked at some subgroup analysis and they said, well, it reduces the hospitalization, and that's why FDA approved it. And patients are getting $3,000 per vial treatment that most likely is not going to work. Getting off track. Let's go back. Oh, and then last one is composite outcome, and we're going to focus our talk today on composite outcomes. So composite outcomes is when instead of picking one primary outcome, you combine 2, 3, or even more outcomes together as your primary outcome. And if the patient meets any of those endpoints, then they meet the primary outcome. Why would people do that? Before I go into composite outcome, I couldn't resist to put this on. This is regarding ischemia trial. I don't know if you've heard of ischemia trial or not. You know, there has been a lot of talk about whether patients who have a stable coronary artery disease, whether they need stent or not, right? Because everybody who has an abnormal EKG, everybody who has an abnormal stress test gets angio, and then they put the stent in. And many studies showed that it really doesn't help anyone. The cardiologists said, we're going to fix this. We're going to do a study that we not only look at the obstructive lesions, but we're only going to put the stent if the flow beyond that obstructive lesion is decreased. So they said, you know, to put a stent, you need a 50% blockage in the coronary artery plus reduction in FFR, the flow beyond that. And they said, if we do this, we're going to prove that the stents are useful. So the cardiologists are high-fiving each other. The pre-orders for Tesla and Mercedes-Benz were going to the roof because they knew that this was it, right? So this is the ischemia trial. The fishy thing here was that initially, as you can see here, the primary outcome was a composite of death from cardiovascular causes, myocardial infarction, or resuscitated cardiac arrest. They had 3 composite outcomes when this study started. Halfway through the study, they looked at the data, they were not supposed to, and they said, oh crap, this is not good, this does not look good. So halfway through the study, they added 2 more outcomes to the composite outcomes. They made it 5 composite outcomes, some of which they were sure, you know, hospitalization for unstable angina and heart failure. They were sure that these 2 are going to make the results statistically significant. Guess what? It didn't. So this is the largest study on stents or PCI in patients with stable coronary artery disease. And despite data manipulation, despite changing the outcomes halfway through the study, it showed that it doesn't change. It has no benefit. Getting off track again. All right. So why do we do composite outcomes? First is it increases the statistical efficiency. And in my next slide, I will tell you what this statistical efficiency means. Second, but the main reason is sometimes it is very hard to, you need a lot of patients to reach a meaningful patient-centered primary outcome. Like if you want to do mortality in a cardiology study, you need thousands and thousands and thousands of patients to have enough people who reach that endpoint of death to see if there's a difference. So it is not unreasonable to make 2 composite outcome or 3 composite outcome together, as long as they are meaningful and we'll say what kind of, when that's useful. But that's the main reason, because in order to reduce the number of samples, the number of patients that you need, shorter duration of study, less resources, less money, they combine the outcomes together and they create composite outcomes. It's mostly for reducing the sample size and reducing the resources that are needed for the trial. The caveat, it is most likely when you do composite outcome, it is more likely that you reach a statistical significance. And that's what statistical efficiency means, because when you combine the outcomes, it's more likely that more patients will reach one of those endpoints, and then it is more likely that you will reach a statistical significance. This is one of the main reasons why pharmaceutical companies love composite outcomes, because it is more likely that they will reach significant statistical significance. The other issue is sometimes you combine the outcomes that have different clinical importance. And we'll talk about this in the next few sentences. And lastly, you don't know how frequent each outcome or each endpoint is going to happen. If you're combining, chest pain plus something else, if chest pain happens more often than the other endpoint, then the data is going to be skewed and it's not going to be meaningful. We'll talk about that also next. So the composite outcomes are not going anywhere, right? More and more people are using it. We know why, we know the advantages, we know the disadvantages, but let's see how to treat them when we see them in a paper. So there are 3 criteria that you should keep in mind. When you see a composite outcome, ask 3 questions to see if this composite outcome is valid or not. The first is whether these endpoints that are being combined are important to the patients. They have to be patient-centered outcomes. They have to be important not to the researchers. They have to be important to the patients, right? Example. This was a study that was done for efficacy of systemic corticosteroids on exacerbation of chronic obstructive pulmonary disease. This was a large randomized control trial. They combined, they had a composite outcome, and they showed that treatment with systemic glucocorticoid results in moderate improvement in clinical outcomes among patients hospitalized for exacerbation of COPD. But look at the composite outcomes. You have death from any cause. You have death from any cause, need for intubation and mechanical ventilation. So far, so good. Readmission to the hospital for COPD, but intensification of drug therapy, right? Do the patient really care about this? Is this the same value as death or intubation, right? So they combined outcomes that are not important to the patient, or at least not of equal importance to the patient. So that's the first on your checklist. When you look at composite outcome, look at the elements of or different endpoints and see if they are important to the patient. And if they are not, it's not, combining the endpoints is not justified. Second question that you ask, how frequent each endpoint happens, right? Are all the endpoints happening with the same frequency? This was a randomized control trial, a very large trial of invasive versus medical therapy in elderly patients with chronic symptomatic coronary artery disease. And as you can see, the primary endpoint was major adverse cardiac events that included death, non-fatal myocardial infarction, or hospital admissions for acute coronary syndrome. So there are 3 elements of composite outcomes, and they all, kind of look decent. But look at the numbers. If you look, you see that on the top row, death, the numbers are very small. The difference is not statistically significant. Second row, fatal infarctions. The numbers are small. The difference is not statistically significant. Sophia, can you make this just not the presenter thing? I want to use the cursor here.
Like this?
Yeah, perfect.
Okay. Let me just change it. They're gonna have to, I just have to move it here for 1 second.
Perfect. Where did it go?
It's over here. I just have to move it.
But can you put it on the presentation mode?
Oh yeah. You want on presenter mode?
Yeah, no. I mean, somewhere that I can point my.
Okay, let's do it this way. Okay, this will work and they can see what you're doing.
Okay, I just want to use the cursor to show.
Yep.
Okay. So as you can see, death here, the numbers are small. Didn't happen enough times, and the difference was not statistically significant. Non-fatal infarction, small numbers, small frequency, not statistically significant. But out of 96 patients who met this composite outcome, 74 of them were hospital admissions for ACS. So only one of the endpoints contributed to the majority of the numbers. So if they did not have this hospital admission for ACS here, the difference would not have been statistically significant. So when you see that the frequency of occurrence of these endpoints are skewed, something is wrong. This is not valid. Is this clear? So the frequency of each outcome included in the composite outcome has to be similar, and it cannot be that one outcome contributes to the majority of the N at the end. And then almost similarly, if I can do it, that's okay. Just the one or two slides left.
Okay.
And then the third element that you have to pay attention is if the outcomes are chosen properly and they're biologically correlated and plausible, the relative risks and absolute risks should be similar, should be close. All of them have to be significant or not significant. If one particular endpoint is significant and the other endpoints are not significant, then the choice that you have made combining these might not be appropriate. This was a study, cardiovascular morbidity and mortality in the losartan intervention for endpoint reduction in hypertension. So they studied patients with essential hypertension, and one group had just beta blocker, the other group had beta blocker plus losartan, and they looked at the composite outcome of death, myocardial infarction, and stroke. And they showed that losartan reduced the composite outcome significantly. The elements of composite outcome, they all make sense, right? But when you look at the data, the primary composite endpoint, the composite endpoint was statistically significant because you can see it doesn't, the relative risk doesn't cross 1. Whenever the 95% confidence interval for relative risk doesn't cross 1, that's statistically significant. If the 95% crosses 1, that means at some point the risk in the placebo group was the same as the intervention group, and it's not statistically significant. So ignore the primary composite outcome for now. Look at the cardiovascular mortality. This is the relative risk, and the confidence interval crosses 1, right? This is not significant. Look at myocardial infarction. Relative risk crosses 1. It's not statistically significant. Only stroke is actually statistically significant. So when you look at the outcomes included in the composite outcomes separately, you want the relative risks or absolute risk to be similarly significant or not significant. And in this case, the only thing that mattered was the risk of a stroke. The treatment had no effect on cardiovascular mortality and no effect on myocardial infarction. It was just the stroke that contributed to the final outcome. So again, three things that you need to pay attention to when you look at composite outcome. A, are all the elements of composite outcome patient-oriented and important to the patient? Important to the patient, not to the researchers. Two, look at the frequency of occurrence of each endpoint. They should happen with similar frequency. If one outcome is happening more common and more often and more than the other two, then the composite outcome is not valid. And third, look at the relative risk or absolute risk for each endpoint. They should have a similar level of significance or not significance. This is the conclusion. This is what we talked about. And before we go to the small group, when I was reading this paper, I came across modified intention to treat, and I really didn't know what a modified intention to treat is or was. You know, intention to treat is you randomize people to one intervention versus placebo, and no matter what happens, they have to be analyzed in the same group as you assign them. If they are assigned to the surgical intervention and they don't get surgery, they still are analyzed in the surgical intervention group. And if they're in the placebo group and they accidentally get the treatment, you still analyze them in the placebo group. When I read a couple of papers, and this one, the conclusion actually came, it's very clear. So modified intention to treat means there's no intention to treat, right? Because that modified means they are covering up the exclusions. And in this case, when you read the paper, pay attention to this modified intention to treat. They don't define it, but when you look at the results, you will find out why they called it modified intention to treat. Okay, any questions? My pleasure, thank you.
All right, so for those of you who don't know, this trial is part of the larger EMPACTA trial, which none of us have any idea what it actually stands for. But I assume the T stands for Tocilizumab. I'm not really sure. So let's just briefly kind of wrap up what we talked about today in terms of this paper. So I'm just going to talk a little bit, kind of what we talked about through the discussion groups, trial background, the results that, and then we'll talk a little bit about the composite outcome analysis that happened in this paper. So to go back to that PICO that we learned in med school and that we love so much, this trial was on patients who were hospitalized, adult patients who were hospitalized with COVID-19 pneumonia. The intervention was tocilizumab. The comparator was placebo, and the outcome of interest was mechanical death mechanical ventilation or death. So in all, trial was essentially looking at tocilizumab versus placebo in hospitalized adult patients with COVID-19 pneumonia, looking at the outcome of mechanical death or ventilation. It, as we talked about, was a multi-center randomized controlled trial, placebo-controlled, and it was double-blinded. Patients were randomized 2-to-1 to receive either tocilizumab or placebo. And it was adult patients who were hospitalized who had oxygen saturations less than 94% on room air, but were not yet requiring any kind of mechanical ventilation or non-invasive pressure ventilation. So what were the results? Like we talked about, the primary outcome of interest was a composite of mechanical ventilation or death. This was considered, as reported by the authors, to be statistically significant with a p-value of 0.04 in favor of tocilizumab. However, the hazard ratio, as you may have talked about in your small groups, was 0.56 with a confidence interval that was 0.33 to 0.97, just barely making it under the cutoff of 1. And this was all at the 28-day follow-up. In terms of the secondary outcomes they looked at median time to hospital discharge or readiness for discharge. They looked at median time to improvement in clinical status or median time to clinical failure. None of these were statistically significant. They all had very similar numbers between the tocilizumab and placebo group. And then finally, at the bottom, they looked at death, which they did not calculate a confidence interval for. They didn't calculate a p-value for, sorry. And the numbers are a little bit different, a little bit more in the tocilizumab group, 10.4% versus 8.6% in the placebo group. So what do we think about these composite endpoints? As Dr. Z spoke about earlier, the three things that were the first thing that we want to look at when we're looking at composite endpoints are they of similar importance? Not to us, not to the clinicians, not to the researchers, but to the patient. And yes, I agree that death and mechanical ventilation are both very important to the patients. Obviously, family members don't want to see their patient on mechanical ventilation. Mechanical ventilation often is a precursor to eventual death. However, I personally would argue that they're not entirely equal because, death is final and mechanical ventilation is temporary, or it's supposed to be. So, I would kind of argue at this point with maybe they are similar, but I think there's room to say that they're not necessarily 100% equivalent. Second thing, are they similar in frequency? This was the second point that Dr. Z made. So when we're looking at the total population that was included in this study, the numbers were 9.8% death and 9.5% mechanical ventilation. So very, very similar in terms of the overall population. When you break it down a little bit more, among patients who received tocilizumab, there was 10.4% death and 8% mechanical ventilation. So more death in the tocilizumab group than in the than mechanical ventilation. And then when you're looking at the placebo group, it actually switches and you have 8.6% death in the placebo versus 12.5%. So you kind of see a crisscrossing where there is a higher percentage of death in the tocilizumab, higher percentage of mechanical ventilation in the placebo group. So it's a little bit unbalanced. Overall, the numbers are not drastically different, but it's a little bit odd how they kind of crisscross there. So finally, what are the relative risks of the component endpoints, mechanical ventilation and death? Well, if you look at tocilizumab, and this data is from the supplement, you see that the relative risk of death for tocilizumab is 1.22. So technically 22% increase in relative risk. However, the confidence interval is 0.62 to 2.38. So crosses 1, your p-value is 0.57, it's not significant. Similarly, if you look at mechanical ventilation in the tocilizumab group, the relative risk is 0.64, yay, it's better. However, the 95% confidence interval is 0.35 to 1.2, again, crosses 1. Your p-value is 0.16 and it's completely insignificant. So taking that all together, if you're looking at the relative risks of these two component endpoints that make up the composite outcome, you have two completely non-significant outcomes that only when put together create a composite outcome that the pharmaceutical company can say, hey, we have something that works. And I think that this is kind of case in point of why composite outcomes end up being dangerous when we're looking at clinical trials and why the pharmaceutical companies love them so much. So to kind of sum it up, when we're looking at the use of tocilizumab in COVID-19 in hospitalized patients, I think overall, this was a great design for RCT for a pharmaceutical company. And to get published. I don't think that it's a great design for an RCT in terms of patient-oriented outcomes and patient-centered outcomes. We see that when we break it down into its component parts, tocilizumab has no role in preventing death from COVID-19, at least among this population. We see that tocilizumab is not useful in preventing mechanical ventilation by itself among this population and has no role there. And so overall, I think it's really good to just keep this study in mind because, well, not the interns, but the rest of us kind of suffered through COVID, and we saw all these patients, that we had these high hopes for these pharmaceuticals that came out. And so, you know, keep this as a case study in your mind of when you're looking at these clinical trials, particularly as we spoke about in cardiology, that use major adverse cardiac effects or events as this composite outcome, and use this as a trigger to remind yourself to be very wary of these composite outcomes and to look at the individual components and look at the supplement if you have access to it to see actually how those component endpoints play into the composite outcome. I want to thank the EBM team for working with me, helping me through this, and that's it. Questions?